test is sulcus sign. Sulcus sign is with the elbow flex, and you pull inferiorly at the elbow and support at the shoulder, like this. The indication is a glenohumeral separation. Also, you're looking for as a AC separation, and also by palpation or by visually. Okay. Our second test is the anti-can test. Anti-can test is with the elbows flex at 90 degrees and internally rotate with thumbs facing down. Okay. Flexion is Nick is going to pull upward. Nick is going to flex upward, and I'm going to resist down. Okay. We're looking for a bilateral compression on supraspinatus, weakness, or damage.
So when we suspect that a patient or an athlete has had a luxation or subluxation of the glenohumeral joint, one of the tests that we'll do is called the Apprehension Test. Patient lays supine. I'll have you scoot over a little bit towards the edge of the table. Perfect. There is fine. The humerus is abducted to 90 degrees and the elbow flexed at 90 degrees with external rotation. The first time we do the test, supporting the elbow and at the wrist, we're trying to recreate the mechanism of injury by extending the arm and putting it into external rotation. Positive signs would be facial expressions or the body will jump. They're basically showing apprehension. They don't want to do the movement. If the patient is positive at this point, we'll support the GH joint, the glenohumeral joint, and do it again. If the support helps and the pain goes away, that is also a positive sign of possible luxation of the glenohumeral joint.
This is speed test. First, you palpate the bicep tendon up to the bicipital groove. Once you find that, you put the arm in external rotation at the shoulder and place your other arm on the forearm. You ask the patient to raise their palm to the ceiling against my resistance. Go ahead. Stop. A positive test would be pain or weakness of the bicep at full extension. Positive indication would be bicep tendon.
Our next test is mirror. You want the patient short sitting with their arms flexed and internal rotation. Stabilize the shoulder and wrist. Have them get them in full flexion, and at end range of motion, you want to check to see if there's pain. That's an indication of impingement of the glenohumeral joint. Our next test is Hawkins Kennedy. You want the patient short sitting with arms flexed at the elbow and at the shoulder. You want to support the elbow and internally rotate. Positive sign is impingement of the supraspinatus. Our next test is the AC compression test. The patient could be short sitting or lying supine. Place one hand on the patient's clavicle and the other on the spine and scapula. Gently squeeze your hands together, looking for any separation in the clavicle. Gently squeeze hands together, looking for movement of the acromion-clavicular joint. Positive test is pain or movement of the clavicle. Positive test implications are acromion-clavicular and or corticoclavicular ligament sprain.
The next test is Ludington. The patient can be either sitting or standing and place their elbow in 90 degrees of forward flexion with their forearm in the neutral position. You place one hand on their forearm and your other hand on the bicipital groove. You ask them to actively supinate and externally rotate their forearm as you did. So, a positive test would be pain and or snapping in the bicipital groove, and a positive implication would be bicipital tendinitis or tear in the transverse humeral ligament.
Our next test is the Ludington's test. Ludington's test is when the patient is sitting or standing, has his fingers interlocked superior and posterior on the aspect of the head. The examiner stands behind the patient, places the hands bilaterally on the long head of the bicep. Patient contracts biceps brachii, applying force to the top of the head. Examiner notes any tension on the bicep brachii. Positive test is decreased tension that is felt under the bicep tendon. Positive test implications is rupture of the bicep tendon.
The next test is O'Brien's active compression test. The patient could be either sitting or standing with their shoulder in 90 degrees of flexion and the arm horizontally adducted 30 to 45 degrees with maximal internal rotation. You place your arm, you place your hand on their forearm and ask them to horizontally abduct and flex their shoulders against your resistance. So go ahead. Stop. The test is then repeated in external rotation. Go ahead. Stop. A positive test will be retained or copied in the internally rotated position, but absent in the externally rotated position. Positive implication will be a slap parent.
So now we're going to perform Adson's test, which is testing for thoracic outlet syndrome. The patient can be sitting or standing. Arm is extended and externally rotated, checking for radial pulse. Once the radial pulse is found, you ask the patient to lean their head back and turn towards the affected arm. Take a deep breath. Positive sign is an absent or diminished pulse, and it indicates compression of the subclavian artery by the anterior scaling muscle. Now I'm going to perform Allen's test, which is checking for thoracic outlet syndrome. The patient can be sitting or standing. Elbow is flexed to 90, shoulders abducted to 90, and slightly externally rotated. At this point, the examiner palpates the radial pulse. Once the pulse is found, the patient is asked to turn their head away from the tested arm. Positive sign is absent or diminished pulse, and the indication is thoracic outlet syndrome. I'm going to perform the military brace position test, which is checking for thoracic outlet syndrome. Patient is standing. Examiner stands behind the patient. The arm is extended and abducted to about 30 degrees. Examiner palpates the radial pulse. Once the pulse is found, the patient is asked to hyperextend their neck by leaning back as far as they can, tilting the head back as far as they can. Positive sign is a diminished or absent pulse. Indication is positive for thoracic outlet syndrome.